there, FILIPINARS listeners and followers. It is that time again for our podcast. So how are you all doing? We hope that you're all well. Thank you so much for joining us today. And as you know, the FILIPINARS is brought to you as a public service project of the PNANV, or the Philippine Nurses Association of Nevada, in collaboration with PHLV Radio. So, first of all, I'm very excited today to introduce you to my co-host today, Ms. Catherine, we call her Kay Fontanilla.
Hello.
So Kay is a nurse educator from the Nevada State College, and she is also going to be our president-elect.
Next year.
Next year.
Thank you for that intro.
Anything else to say about that?
Oh, okay. It's my time to say something. Okay.
Sure, why not?
Yeah, we are going to continue what we have. Miss Emmer has started. She has a lot of initiatives that probably a couple or three. I'm not going to make any changes, but continue and hone on those initiatives that she started, and that's a promise.
All right. That's a promise. Okay, that's good. Okay, so on June 9 of 2026, Nevada heads to the polls for primary election day. With over 517 positions up for grabs, from congressional seats to local judgeships, this election will shape the direction of our state in big and small ways. For healthcare workers, these decisions hit close to home. The laws that influence staffing, safety, funding, patient protections are written by people who may not fully understand what it takes to deliver the care that healthcare providers provide. So that is why the voices of healthcare professionals matter. And their frontline experience brings clarity, context, and truth to the policy discussions, and helping to ensure that the rules guiding healthcare actually support the people who rely on it. So for today's podcast, we have invited a healthcare professional, a doctor as a matter of fact, and we need to please welcome Dr. Aury Nagy. Welcome, Doc.
Thank you so much for having me today. I really appreciate the opportunity to be here.
Oh, good. Well, I'm gonna read a little bit of a snippet of all about you, and you can add on it.
Sure.
Okay. So Dr. Nagy has been a resident of Nevada for a long time. He went to Bishop Gordon in a hospital. I mean, in high school, right?
Yeah, I got here in 1974. When I was 3
Oh
years
my
old.
goodness gracious! So he is Yale educated, and he's a neurosurgeon and a former president of the medical examiners. He has spent his life in healthcare, working in Nevada, and in including, affordable solar energy to the people, creating the Nevada Nutrition Coalition and more projects. So welcome.
Impressive.
Yes. You were also working at UMC, right?
I was. I
used to work there too.
You were told me when we last met.
Yeah. So do you have anything to add to that?
Yeah. So I was chairman of the Department of Neurosurgery over there while I was over there, and we got to help improve things, reduce mortality in the spine program. We got to upgrade some things in terms of the way they manage spinal cord injury, which is important. And I got to observe the process by which hospitals around the country have been instituting policies by which they assert more control over the physicians and the people who are on staff. So it was quite interesting. While I was there, UMC was in the process of adopting policies from a company called Greeley. And Greeley is a company that sells a version of the bylaws for the hospital to administrators, and so they encourage the physician members of the medical executive committee, which is supposed to oversee quality of the hospital, to discard their old bylaws and to adopt the new bylaws. But the new bylaws are very heavily in favor of administration, and they strip the physicians really of a lot of the ability that they had to oversee care. And this is a problem that goes on at a lot of hospitals around the valley, wherein doctors feel like they are very much under the heel of administrators, and if they complain about any of the policies that are put forward by hospital administrators, their privileges at the hospital can be threatened. They can be removed from staff, and that has tremendous consequences to their licensing, to their hospital credentialing, to their malpractice qualification. Sometimes, so doctors very much have to abide by the policies that the hospital administrators set down, and sometimes though the hospital policies are much more in line with what's in the financial interest of the hospital than what are in the patient's best interest. And very frustrating for physicians.
Yeah. Well, thank you for that insight, Dr. Nagy. Ms. Kay, you have anything to ask?
You might have. You might have partially answered this first question. Thank you for joining us today, Dr. Nagy. As a longtime healthcare professional and leader, why do you believe it's important for clinicians to be involved in public policy and legislative discussion? Was there any patient experience or healthcare challenges that made you believe that that there needs to be a change beyond bedside?
I mean, many. But the one that one of the most recent was when I was on the board of medical examiners. We created a subcommittee to look over all of the bills that were being considered by the legislature, that were dealt with healthcare, and we came to decisions about what we thought was going to be in the best interest of the people in our community from the perspective of the board of medical examiners, and we sent that information to the legislators. And it turned out that they didn't receive those. Our lobbyists, it turned out apparently their daughter, the daughter of our lobbyist, worked for the hospital lobby, and so suddenly they didn't transmit any of the information. And so then I started paying very close attention to what happens to these legislators and how do they make their decisions. So we get 60 very nice people who go up to Carson City every 2 years, and they do their best to pass laws for the best interest of the people here. But the information that they get about what those laws should be come primarily from very well-paid lobbyists. And in healthcare, the lobbyists are for the hospitals, the insurance companies, the hedge funds that practice medicine, the pharmaceutical companies, and the personal injury attorneys. But there's almost nobody there representing the patients or the people who take care of them.
Right.
And so the laws in our state, year after year after year, get tilted more and more in favor of these gigantic corporations and against the people who live here and the people who take care of them. So the point now, they almost have no rights at all.
Yeah.
And so when I realized that's what was going on, I kind of got a bit depressed because there's so many things that are broken in healthcare, and we thought, if we proposed laws that they'd start to get fixed, and there was nobody listening, it seemed.
What a big frustration for everybody in the healthcare and, of course, patients.
So I came across an article written by an economist at UNLV, and it said that there are 150,000 people in Nevada who work in healthcare. So that's 5% of the state's population. I thought if they all have a significant other, that's 10%. And if they all have one friend who cares about healthcare, that's 20%.
Right.
And if only half the people show up to vote in an election cycle, that's 40% of the electorate. And with 40% of the electorate, we can get anybody elected to anything. So when I was president of the board of the MD board, I called the president of the DO board and the dental board and the chiropractor board and the nursing board and the optometry board. There's about a dozen of these allied healthcare boards. And I said, hey, are you guys seeing the same kinds of problems that we're seeing? And they all said, yeah, we're seeing these gigantic corporations take over healthcare. We're no longer able to take care of our patients as well. I talked to one nurse, she started crying when she spoke with me. She was so happy somebody's finally doing something to fix this. And when I talk to lay people about it, I try to explain what's going on in healthcare, and I explain it as follows. I say it's like you're standing at the edge of a swimming pool, and you see somebody drowning in front of you, and you know what to do to save that person. It's like you reach out your hand to help them out of the water. But when you reach your hand out, it's like the insurance companies and the hospitals grab your arm by the wrist and hold it behind your back, and I have to stand there and watch them drown. And you do that day after day and week after week, and it breaks people.
Yeah, it does.
And people, they leave the community, they go to other states, they commit suicide, they stop working in the profession anymore. People get very broken and depressed by this. And it was especially bad during COVID. When all the doctors and nurses were out there, they were on the front lines putting their lives at risk because they didn't know how dangerous this disease was, and so many of them died. They never caught COVID and died when they were saving other people's lives. And and to see the way that they all get treated now is appalling and disturbing.
Were there initial responses that you gathered from you connecting with?
So I connected all those folks, and I said, listen, we're going to create a fake political party. and we're going to call ourselves the Scrubs Party because we all wear scrubs.
Love it.
So,
That is cute.
Yes, that's cute.
and so we would meet, once a month or so, and we'd say, okay, these are the problems and what are solutions. And so whatever we wrote down, the next time we met, those would be the solutions. They'd be laminated, and then people would have like red markers, and they'd kind of just cross through stuff, and that'd be the next version. And over the course of a year, we came up with about 30 solutions. And so we said, okay, we'll take these to the legislature, and we'll start to pass them around. So I got registered as a lobbyist. By then, we had to change the name of the party. Nobody wanted to be Scrubs anymore because Scrubs can't get no love.
Can't get no love.
Oh my goodness.
So we picked the name White Coat Party.
White Coat Party.
Because we all wear white coats,
Very
and there's a
nice.
red party and a
Yes.
blue party, but White Coat Party everybody can get behind. It's right down the middle. Everybody, healthcare affects everybody, and proving that's a big,
That's a great idea.
and so we built this, this nonpartisan coalition, and we figured, there are 53,000 people who work in healthcare in this district, CD3, and so we could get a lot done. And so I went up to the legislature and I started bullying the legislators. I said, listen, you will either pass bills that improve health care, or we will remove you and elect somebody from our own ranks, and they will absolutely win because we have the numbers. And this cycle, there were more bills put forward to improve health care than they've ever had in a single cycle. So we got some good things. And we did help get at least one of the bills passed, which was a bill to limit the ability of insurance companies to deny things. So I got to work with folks at HEALS over on that. And I did testify on the SB 182 bill.
Yeah,
which was
that's
very
what
important
I
for
was gonna ask you, because
Follow up,
Nevada is one of 7 states in the entire nation that is not a compact licensure state. And this would have been, if this would have been passed in COVID times, we would have been great. But no, I mean, there are many entities that are opposed to this, a lot of lobbyists against this. Many nursing organizations, including the PNANB, actually support and have been trying to campaign to, become a compact licensure state. So the last legislative session, we even included the nurses as a major proposal by somebody who came from the governor's office, as a matter of fact, who combined a compact licensure request for physician's assistants, nurses, audiologists, physical therapists, and all that. It never even got to the floor.
It didn't make it.
It didn't even make it. So, what's your opinion on this?
So I know on the MD board, we're part of a compact, and when I last checked, there were 38 states that were members of this. So and that was part of the plan that we had to dramatically reduce the amount of time it takes to get a license. When I first got there, it was something like 9 months it was taking, and we compressed it down to about 2 weeks if all the paperwork's in order for people, which is good. And it would be fantastic if something could be done like that for nursing, because anything we can do to get more nurses here is a benefit to the people in our community. We very much need that.
I predominantly have worked in home infusion, home care. So we're looking at patients who are in the border states or in rural Nevada, actually, whose nearest access to clinic is the state next to, which is Utah or whatever. But they actually have somebody in their a neighbor who can actually help them possibly, but it's limited by, the geographic limitations of a home health agency. So they cannot take care of this person. So it's a big challenge, not only up in the Utah area, but also in the Arizona. I myself have a license in Arizona, but but I am not a compact. We are not a compact licensure state, so I got to have a separate license to even take care of.
That is similar to me as an educator. I also have licenses in Tennessee and Washington to be able to teach other students from other states. So.
Well, I'll be happy to say it now. I am in favor of the nurses compact. I think it benefits our state. We get more nurses here, and that is something that we need. One of the things that came up is that one of the problems we have is retaining nurses.
Yes.
We spent a lot of money getting all of these nursing schools put in place. Millions of dollars were spent. And what happens is, before the end of the first year after graduation, more than a third of the nurses have left. And before the end of the second year, over half are gone. And the reason is they can make, $50,000 more a year in California, take care of fewer patients, and provide better care than they can over here. And that's something that we have to address here, because if you don't have enough patients, or if you have too many patients per nurse, the nurse is going to be overwhelmed. She's not going to be able to take care of it. Just a mechanical fact of how much can you do within 1 hour to see your patients. And if you have 8 patients, it's not possible to do everything that needs to be done for all of those patients and get all the charting. And things are going to get missed. And when things get missed, people can die. And there's many papers that support this. And I don't know why. I don't know why they don't take it more seriously. Because making sure that our hospitals are appropriately staffed is one of the best ways to reduce mortality and to improve the quality of care here in our state.
Thank you for right? Yeah, it did. Yeah, thank you for those data. Those are important data. But
I can bring you the paper sightings. Yeah, for sure.
Well, we honed in on nursing already. So what is your opinion, and this is related to what we have been discussing lately, what is your opinion in obtaining a patient-to-nurse staffing ratio in terms of patient safety and patient outcomes?
Yeah, so that's extremely important, just what we were talking about. In California, the law is that they have 4 patients to 1 nurse. Over here, there is no limit. There's an advisement that it should be 6 patients to a nurse is what they try to cap it at. But I know at Henderson Hospital a few years ago, all the nurses left because they were trying to run it at 8 patients to a nurse, which is, people die.
Yeah.
And I have heard, on more than one occasion, some of the hospitals will run, it's at 9 or even 10 patients to a nurse, which is, when somebody doesn't show up on time and they don't have adequate staffing. And the thing is the hospitals will say, well, we have a nursing shortage, so we can't provide them. But it's the shortage is that there's nobody who's willing to come here to work at the wage that you're offering. Because during the COVID crisis, they were able to get nurses because they kept raising the amount that they were willing to pay for them. So the reality is the hospitals aren't willing to pay a high enough wage to attract nurses here to work and stay. So it's not a question of there aren't enough nurses, it's that they aren't providing a high enough wage to keep them here to be competitive on a national scale. So until they are, we're not going to be able to provide the same level of care that they do in the rest of the country.
Well, yeah, that's, this is a big thing. The staffing ratio didn't pass as well, or it didn't even get to the floor. And the safety of the patients is, and you're right. People leave because it's hard on them. It's burnout, mental health. For nurses, that's a pretty big issue right now. But one of the things is they're saying that there are 4,000 nursing jobs that are open in the state of Nevada, but nobody's hiring.
Well, so I'm not sure. Nobody's hiring.
Nobody's hiring people. They're saying, no, there's no nursing shortage. I said, but there is. Well, we've graduated a lot of people. Okay, there's a lot of
new grads
who do not really have the the experience yet, and they need to go to some kind of a residency program or something like that. But nobody's hiring.
Yes.
Yeah,
it just goes to show there are conflicting information, such as what Dr. Nagy was mentioning regarding these hospitals and institutions that are not marketing or not valuing nurses through, not giving them the rate that other states are giving their nurses. So the nurses here don't feel that they're that valued.
Yeah.
And then hospitals will say, oh, there is really no shortage, so we are not hiring. So we need to straighten up those information, right?
Yeah, for sure. And that's what I think people in healthcare professionals in legislature can help, right?
Yes.
Yeah,
but what can you say about it, Dr. Nagy?
I do think it's important to have to increase the nurse-to-patient ratios here. And when I went and I talked to the CFOs here in the city about what would it take for you to be able to provide appropriate staffing, or if there's one law that you could get passed, and they wanted to prevent the insurance companies from down-coding the things that they bill for. Apparently there's a huge problem with the insurance companies. The hospitals will submit a bill, say this is what we did, and the insurance companies will say, well, we're just not going to pay for that. And they're going to pretend that it's something less than that. So if they were able to fix that, the story that I got from the CFOs was they'd have about $20 million more per hospital, which would be more than enough to pay for all the nurses that they need to staff throughout the year.
Yes.
Yeah, there's a lot of comments, and it's pretty common knowledge anyway that they say that the insurance companies are the ones that are driving healthcare. Any decisions that are made with regards to anything that they have to approve to be done to a patient, it depends on insurance.
Yeah.
So I don't know.
So
how we can fix
they spend
that.
hundreds of millions of dollars lobbying Congress, and the goal is to limit competition and allow them to build more integrated networks. So what's happened is that there's been a vertical integration in healthcare where the insurance companies, ever since the Affordable Care Act, the insurance companies are required now to spend about 85% of the money they get in on providing actual health care. It used to be that they'd spend maybe 40, maybe 60% of the money they get, and the rest they just keep for administration salaries and whatnot. But the Affordable Care Act happened, so they now had to spend 85%. All the administrators were angry, and then they realized they could just, either cut deals or buy the pharmaceutical companies and the doctors' offices and the hospitals, and then just raise the prices on that side, and then take the money out on the backside as a sort of a return back to the insurance company. And in this way, that's a huge part of the reason that prices for everything in healthcare have risen. It's not that they're more expensive on a supply and demand basis.
True.
It's just that the insurance companies are trying to pad the costs so they can pull more money out and have higher profits. They're among the most
Makes
profitable
sense.
companies in the country.
Yeah, for sure.
They're making if they made about $40 billion in profits last year. I think United Healthcare did that, several hundred million per state. Hundreds of millions of dollars are being siphoned out of Nevada to go to Wall Street as profit, and then to the shareholders who may live in China, Russia, Saudi Arabia, the central banks of Europe. If we change that model, we can keep hundreds of millions of dollars here in our state to recirculate back within our own economy.
So
And that's what I've got a plan to do.
yeah. So what do you think a solution to this is? Do you have a solution to it?
So Warren Buffett looked at this and he said, if we don't do something about this, we're not going to be able to compete against China, Russia, India, the central banks, or the China, or the other rising economies of the world. But he didn't say what the cause of the problem was or how to fix it. So the cause of the problem is the structure of health insurance. Today, almost all of the health insurance companies are publicly traded firms. But
Right.
but 30, 40 years ago, they were almost all mutual insurance companies. Because at that time we thought that was the obvious way to keep the CEO's incentives aligned. In the current model, the CEO has two jobs: charge as much as possible and deny as much care as possible. To the extent they do those two things, it maximizes profits for the company, shareholder valuations, and the CEO's bonuses. But it's not in the interest of patients. In the mutual insurance company model, mutual insurance companies like Costco for health insurance, the members own the plan, and so now the CEO is accountable to the members. To the patients. So if the CEO denies care that was appropriate, the CEO will get fired. So instead, that CEO's incentive has to be to provide the highest quality care for the lowest possible cost, which is exactly aligned with what the patients want. And a mutual insurance company model is interesting because at the end of the year, if the insurance company makes a profit, well, it pays dividends back to the shareholders. But that's just the patients or the policyholders. So the next year, instead of charging them a bunch of money just to give it back at the end of the year, they can cut premiums. So in the mutual insurance company model, you can see premiums actually fall. And in the for-profit model, in the publicly traded model, you only ever see premiums rise. And so, so if we go to this mutual insurance company model, we'll have care that's more aligned with what the patients need. We'll keep hundreds of millions of dollars in the state if we limit the mutual insurance companies to state-run entities, and we'll see premiums fall. In fact, when we used to have health care that was run by mutual insurance companies, it cost less than half of what it costs us today. It was only 8% of gross domestic product when it was like that. Now it's 18% of gross domestic product.
Okay, so are you talking that the government should handle this, or it should be handled by private entities?
It should be handled by private
Private.
entities. So there was a group of entities here in Las Vegas that were complaining that the hospitals were charging them too much, and they sort of collectively, there are 29 groups. You saw the billboards you saw the electronic billboards talking about this maybe 6 months ago. And these were all essentially either employer-funded insurance or union type things, and those are essentially the same thing. The people who are benefiting from the program are the people putting the money into the program. And by focusing on those models, and most of those models are doing quite well financially. They're solvent and they're taking good care of their patients. And so we can shift most of it that way. I want to see what we can do to reduce the costs of drug development. So, during the COVID pandemic, we found a generic drug that was saving patients' lives, and we learned an awful lot about what it takes to get a new drug developed. These were generic drugs that we were combining. It was still at least $6 million to get all that together for drugs that had never caused a reaction when being combined. And we can do a lot to dramatically reduce those costs. If we succeed in doing that here in Las Vegas, it'll bring a tremendous amount of business to our city. I was just part of helping to adjudicate on who's going to run the biotech incubator that the city's spinning up.
Oh,
So the city had a
okay.
grant for $10 million to bring a biotech incubator, and if it succeeds,
incubator.
they're going to bring. They think it should bring $300 million worth of business in terms of jobs and high-paying jobs to the city. And our focus for that, if we succeed, will be to direct it to longevity treatments. Because we think we have so many retirees out here, we think we can market Las Vegas around the world as being the global center for staying young and beautiful forever.
Ah, that's really, that sounds
That's on brand
so
for us.
promising.
Yeah, right?
You know, I like that reducing the cost. I'm in specialty infusion, so a lot of these are genetically engineered, of course, and so it costs a lot of money. And a lot of high copays for the patients who basically can't afford,
Yeah,
you know,
definitely.
the treatment for their immunocompromised, cases or the diseases that they have. So I'm just kind of hoping.
Yeah.
You know, speaking of the immunocompromised and those diseases, one of the things that touches on the home health care that you were talking about. So there was a guy who ran home health facilities in Arizona, and he had become an early believer in the sort of metabolic theory of diabetes, and that this metabolic syndrome was a cause of Alzheimer's. And so he started providing more nutritious meals, so higher protein, less carbohydrate meals to the people who were living in these group homes and assisted living facilities. And he started documenting that he was, curing their Alzheimer's. Their Alzheimer's symptoms were diminishing, and they were able to leave the facilities and go back to live independently with their families. And so I didn't believe it. I said, "There's no way this can be true."
Yeah.
But it was only over in Arizona, so I drove out and I visited, some of these group homes. And so I went over and I talked to ladies who were preparing the food. And they showed me how they were making the food, and I was like, "So is this really happening?" Like, "Oh yeah, we make this, and a couple months they go home," and I was like, "Well, get out of here."
Wow, really?
Right? So I would love to see.
Are all those findings documented?
Well, so it wasn't a formal study. He was just sort of announcing this on the internet,
Well,
and I was like, "Is that?" So that's why I went to go eyewitness.
Just to see.
But the nurses who were there that day they had no reason to lie to me. I was just some guy who showed up, and they were employees. They didn't own the company, so they don't
just
really
want to
care.
see.
Yeah. So this is the premise of the nutrition organization that you had, or?
So I kind of, that made me start to believe that, this metabolic syndrome, the science behind it is very good on metabolic syndrome, and sort of the rationale and a lot of the studies by which they show that they're reducing type 2 diabetes and reversing the consequences, and some of the stuff where they're showing where they're reducing the incidence of dementia or the severity of Alzheimer's does seem to be effective.
Right.
And so I thought, well, how do we get this out there into group homes and nursing homes and into hospitals and into the schools? So I kind of started talking to people 2-3 years ago about the idea that, here in Las Vegas we have the best chefs in the world. And we have some of the freshest food shipped in here every morning. And we have some of the best nutritionists at the NFL and the UFC and the NHL and WNBA.
Very interesting, because all I know is
Right.
about neurofibrillary tangles and the decreasing beta amyloids at the top when it comes to
So let me fill you in on the rest of it then.
Alzheimer's.
So a lot of that turns out that this is a system that's developed for handling heavy metal particles and viral particles. And so there's an increase in the amount of heavy metals that are in the environment. The things that they found that were correlated with Alzheimer's disease and developing these neurofibrillary tangles was number one thing that they found was sleep apnea. And so why is that? And so it turns out that sleep apnea, you can't get into a deep sleep cycle. But just like you have these lymphatic channels everywhere else in your body that help remove toxins, the brain has that too, but the channels don't open up until you have deep sleep. You get that delta wave sleep and sort of pushes the fluids out, because it's sort of a pulsing wave that goes through your vessels across the brain. And so that's when your lymphatics open, is when you get that deep sleep. But if the lymphatics don't open, then the toxins build, and that causes the
That's what's
issue.
wrong with me.
And so And so the reason that it overlaps with metabolic syndrome is that if you have improved energy mechanics in the cells in your brain, you're able to better deal with those toxins.
Yes.
And they don't build up in the same way, so you can clear them.
You know that it's funny that you, well, not funny actually, it's great that you had mentioned this, because even with the brain health from the Cleveland Clinic,
Yes.
which also are programs associated with Alzheimer's and brain dementia, part of it, a big part of it, is changing the nutrition.
Absolutely, absolutely. You know, I kind of go back and forth with those guys
Yeah.
about what they're doing and what studies are running, and there's a lot of other studies available too.
Right.
And so you know, we've had a lot of discussions about what I think the best treatments would be and what they're offering to people. And so I think we're going to meet in the middle, and there's going to be some room for improvement over there, which I hope. But definitely nutrition and something we can do immediately. And you know, one of the nice things is that here in Las Vegas we have we don't have a big agricultural industry that's going to force us to use the toxic foods that are being grown. So we can sort of set our own standards without being pushed around by a big agricultural lobby. And we have the 5th biggest school district in the country, and that's there are 330,000 kids in the Clark County School District. That's a lot of meals every day prepared for these kids.
Right.
It's enough that we can generate economies of scale if we were to develop more nutritious food products for our kids. So 3 years ago, I started putting together a board of people who'd be interested in helping us to do this, and people said, "You are never going to get the Clark County School District to agree to this." And, you know, but we tried. We said, you know, okay, we've got a 1% chance, but we're going to keep going. And then we sort of doubled it, and then we doubled it again, and we doubled it again. And before you know it, 8 months ago, I was sitting in front of at a table with the head of nutrition and the head of purchasing for the Clark County School District, two gentlemen.
Wow.
Yeah.
And I said to them, I said, listen, there is nobody in Nevada who is not on board with your mission of improving the nutrition for the kids in our schools. So tell us what you need, and I will see to it that you absolutely get it delivered. There is no resource in our state that we will not, open up for you. And you know, if you make an offer like that, how can they say no, right?
How can they say no?
Right.
That's correct.
So the thought was that in the school district, what they could do to improve things was they could open up the schools to any vendor who can produce a nutritional meal at 5 to 10% better than what the current FDA standards are.
Right.
And as long as they can produce that below the current price, which is like $5.50 or $6 a meal, then they're allowed to sell it to the schools. And so, and I thought it was going to be a huge, big, long process before this ever got implemented, and I was expecting, next year or the year after. But 2 months ago, I went on a ride-along with one of the police officers for the Clark County School District. They all have their own police officers in the schools. And he took me when they were having lunch, and lo and behold, they had a bunch of vendors from outside, and I was like, those guys move so fast. I was very impressed.
Wow.
I was very impressed. And so, and the idea is, so that some of the people who we assembled were nutritionists and public health officials and epidemiologists from UNR and Touro and Roseman and DRI, and we wanted to have as many people as possible, and UNLV, and as many people as possible who could help to document that 2 years from now we can prove that we reduced obesity, reduced diabetes, reduced long-term health problems, improved athletic performance, academic performance, reduced mood disorders, reduced suicide, reduced school violence and teacher assaults and school shootings. And if we could prove this, then 49 other states are going to want to copy what we did over here, and they will want to buy food from the vendors, and they will want to hire the consultants who made all that happen. And that means a lot of money pouring into Nevada. And we're able to do all of that without raising a dime in taxes.
Well, that's good to know. That was my next question: is how are we going to fund this thing? But this is good. Nothing required.
And the people who develop these better food products, they should be able to develop the economies of scale to be able to sell them nationally and compete against the people who are backed by the giant food lobbies. And if I get to, I'm running for Congress. If I get to Congress, I'm going to go and try and help them to do that, because I'm a big believer in this MAHA movement. I think we really need to do a lot to improve the quality of the food and take real control of the FDA and make sure it works on behalf of the people.
Absolutely. I mean, bottom line is nutrition really drives everything, for how we think, our physical, activities and all of that. So not having good nutrition is big thing.
Yeah, and it can lead to Alzheimer's.
Yes.
Yeah. Yes, it can. Yes, it can.
Okay. So there's a couple of things that have been on the minds of a lot of nurses. Because of the passing of the OBBBA, nursing has especially been affected in a couple of ways. One is that the OBBA has maintained that nursing is not a profession, and then which led to, I think this was a definition from the 1960s, and so with the passing of the OBBA, it has limited the amount of loans that can be given to, I'm talking about nurses now, who wants to go into a higher education. They constantly tell us, you have to be a lifetime learner, you have to improve yourself, you have to elevate yourself with your practice and with your degrees.
And our knowledge is based on science.
Correct. And nursing is based on science, the way you do your patients, correct? The way you take care of your patients.
I'm married a nurse, I know.
Oh, cool. So you understand.
So you understand. What's your opinion on this?
So when this came out, I thought about it carefully, and what I concluded was that it's not an entirely bad thing, because what happens when you provide a loan to anybody who's trying to get an education is suddenly all the educational institutions will raise their tuition fees. So if they know that you have the money available, they're going to charge you that. And so nursing is something that we wanted to keep accessible to as many people as possible.
Right.
We saw this take place with, maybe 10 years ago, they had all of those colleges that were spun up, and they were just there to trap people into debt.
Yes.
And the people who came out, they didn't really have any of the skills they thought that they were learning, because it was very difficult for them to land jobs. And so it's unfortunate that they have to use the word profession, because nursing is clearly a profession.
Right.
But for this categorization for the loans, it prevents them from being preyed upon by these educational institutions. Now, I do think that when they go to get a nurse practitioner degree, I think then they become professionals, because they in our state, they are independent practitioners, and they're out there, and they will be able to provide care as do the doctors, as do the DOs and MDs, and so they need to. At that level, they should have access to that kind of funding for that part of the training, and I would be willing to sponsor that as a bill.
Yes.
I mean, nurse practitioners have really been the lifesavers, right?
What was the cap before?
I think it's
200,000.
No, it's 20,000.
No, before.
Oh, before, I don't know what
It
the
was
cap was
almost like
before.
endless. It was almost like endless, but now it's like I think
20,000 or something?
I think it's like 100,000, which is a lot.
So
still.
the hope is that the capping of that fee and the capping of like a lot of the trade schools that forces the prices that these institutions that provide the education that forces them to keep the prices reasonable for that.
True.
So they don't make it unreasonable, so you're paying the rest of your life like a lot of the doctors do for their loans.
Yeah, because for private entities or for private institutions, for just the bachelor's degree, the entry level for nursing is about 100,000, which is a lot.
That's a lot.
How much will these loans? How much will the loans cover? They'll cover up to 100,000 now.
For the bachelor's degree, there is no problem.
Okay.
From the advancing master's to doctorate, that's where they are putting a limitation in their caps.
I see.
Yeah. For the bachelor's degree, there is none, so they can continue making their tuition really high. But of course that's not a good thing, because we don't want our nurses to have so much to owe.
Yeah, no,
Yeah,
for sure.
that's true. And I'm glad we got a different side of the story, because we're getting another side of the story from other people. So thank you for that.
Yeah, no, sure.
Appreciate it.
Sure.
So,
Thank you. So, Dr. Nagy, what is your message to the public? Perhaps you don't know, most of our listeners are nurses or people from the healthcare field.
Well, so you have a voice. You absolutely can have your issues heard. We have the numbers to really get any one of you elected if you want to run for office. If you guys want to get together in the White Coat Party and help provide leadership, we would love to have you. And then, help us to draft the laws that need to be pushed forward to the legislature. And they will listen, because they need to listen, because they want to stick around. And so, we'll continue to hold them accountable. because it's a very important part of
Yes.
government is having people who participate.
Yes.
Very good.
Yeah, thank you for that message because nurses, they are very busy, 12-hour shift. They do not know that they can make an impact for their practice and as well as patient care, patient outcomes.
Yeah, that has been a big issue with nurses. They cannot, for some reason, cannot get together to come up with one voice
Yes.
and get together. So we're trying to change that with, of course, what we do at the PNANB and
Yes.
the podcast. And
How is the BNANB doing? Are you guys having success with growing your numbers and having influence?
very, very difficult.
Okay.
Very difficult because a lot of them say we're too busy. What's the benefit for me? And all of that kind of stuff. So we struggle, but we're okay. I think we're okay.
Yes, we offer educational seminars, conferences for
Twice a
free
year.
for our members, and our members do appreciate that because we make sure that the topics that we share are relevant to their practice. Cutting edge technologies.
We are actually part of the
Yes.
education
We
committee.
try to look up for topics
Yeah.
that definitely again are relevant to what's happening
We
to
had
healthcare.
our last topic. Well, we honed in on AI at one point, and then we honed in on the wound care, and then the last one that we had was what was the one? we
Leadership.
had? Leadership.
Yeah, but
So-
I'm interested in because our population, our elderly population is
Population.
growing, and there are a lot of dementia, and maybe we can tap on neuro.
Yeah.
So for sure, the American Association of Anti-Aging Medicine meets here every year. They do 4 meetings a year, and one of them is always here in Las Vegas. And at that meeting, all of the top thinkers on what's the latest in anti-aging therapies, they come and they sort of give their pitch on what they have to offer. When I go, the people who are at those meetings are mostly nurse practitioners. It's at least 75 to 80% nurse practitioners and about 20% physicians. And there's all kinds of things over there, and some of them are going to be beneficial, and some of them, might be a little flam.
Oh, is this a national group or?
It's a national meeting, and then all the vendors come in, like any convention.
Yeah.
But there is not an organization that gives the nurses confidence that what they're doing is sort of approved by any organization. So I've been talking to a group of doctors here about, hey, would you guys be willing to be that organization that sort of helps give these people sort of an official branding, like, hey, so they have confidence and like
Let's do that
a
on
set
your
of protocols.
presidency.
Well, yeah, no, absolutely. So
Yeah,
we
that
would
could
love.
be an initiative.
So 2 weeks ago, I was at an event. 3 weeks ago, I was at an event, and I met a gentleman, and he manufactures exosomes. And he said that he would be happy to fund the education operation and setting up this little school. So if that helps what you guys are doing, maybe I can connect everybody and we can get it off the
please.
ground.
Yes, that
Yeah,
would be-
we're
that would be
always
awesome.
looking for people who can give us grants and stuff like that. Because we do have initiatives that are centered towards patient care, towards the improvement of the practice
Yes,
of nurses and
nurses.
things like that. So we are partnering with other organizations like HFAN, which is Healthy Philomnion. Nyon is the vernacular for town or like a community.
Nice.
So,
Yes.
and part of that is also, includes the education, getting people aware of
And don't
what's
forget
going on in the community.
multidisciplinary involving
yeah.
other disciplines
And
as well.
and we are also connected with the NNA, the Nevada Nurses Association, and some other.
Now, there are 3 big unions here for nurses in Las Vegas.
Is it 3 or
right?
2? 2, I think.
There's
is
one.
SEIU, the other one is
SEIU
CNA.
is not nursing, but
Well,
they
It's not
CNA.
nurse. Okay.
CNA.
Yeah,
California
Nursing
Nurses Association.
But
I don't know of the other one if you're referring to another one. I only know of CNA.
SEIU.
Yeah, but that's
right.
But
that's a whole. But
whole.
they have a faction for the nurses as well.
Yeah.
Yeah. So I saw that one, and I saw the CNA.
Yes.
At that SB 182 hearing.
Yeah.
And then there was one for there's one that seemed to be aligned with the hospitals, maybe the NNN or NNV or something like this.
Yeah, that must be a
NNA.
hospital. Yeah, must be NNA. Yeah. So, anyway, wow, that was a lot to take in.
Yeah, I know. Well, there's a lot going on.
There's a
Healthcare's
lot going
complicated
on.
topic, but we can get it
Yes.
fixed.
Yeah, we're glad that you are pushing through or
Yes.
trying to give us some information about how healthcare can be fixed. So.
Yeah, so you can check it out at whitecoatparty.com. We've got a lot of the information about it over there.
Whitecoatparty.com.
Yes.
Or I'm Dr. Aury Nagy. You can look me up, and can I mention?
Yeah, we'll look you up.
Okay. Yeah.
Yeah.
But I'm going to look up the whitecoat.com.
Yeah, the white coat.
too.
Yeah, I know. Well, anyway, Dr. Aury Nagy, thanks so much for joining us today and giving us an insight on the different issues here in our state. And just as a reminder to everyone, the PNANB, or the FILIPINARS Association of Nevada, is a nonpartisan organization, and we do not endorse anyone who's running for office, but we just want to give the public a chance to know how healthcare professionals, when elected to office, can actually help. So thank you so much for joining us today. And of course, go out there and vote. It's your decision. Okay. Anything
Thank
else
you,
to add to that?
everyone.
Thank you. Okay.
Thank you all very much.
And so to our listeners and followers, we leave you with this. Having healthcare professionals in the legislature isn't just beneficial, it's essential. Their firsthand experience ensures that health policy reflects real-world practice, not only in theory. They bring a critical voice to the underserved communities, help counter misinformation, and advocate for a safer and more sustainable healthcare workforce. And more importantly, they help bridge the gap between the policy and patient care, translating clinical realities into laws that actually work. So when clinicians step into the legislative arena, they can help shape a future where healthcare policy is practical, equitable, and truly patient-centered. So thank you very much for joining us today. Please be safe and be well. Until next time, this is Doris Bauer, your FILIPINARS host, signing off for now.